Good evening. I'm Judy Reese-Morse, President and CEO of the Urban League of Louisiana, and I'd like to welcome you to No, We're Not Immune, the Impact of Coronavirus on African American Whole Health. This special Tele-Town Hall is brought to you by the Urban League of Louisiana and the Louisiana Public Health Institute, led by Gerrelda Davis, CEO, whom you'll hear from in just a few moments. We have a powerful evening in store for you. National and local guest speakers, health experts from across Louisiana, all to speak about the impact of COVID-19 on African American whole health, physical, mental, and spiritual. Before we get into it, this town hall is being recorded. All participants' lines are in listen-only mode. After our speakers' presentations, you can enter a question using the question box to the right of your screen. Following the town hall, the recording will go up on the websites of the Urban League of Louisiana and the Louisiana Public Health Institute. A little more than a week ago, data surfaced that spoke to an alarmingly high percentage of African Americans who have died from COVID-19. And while many were shocked, many others weren't surprised at all, knowing about the health disparities that exist in our country. It is important data that must be discussed, understood, and acted upon in order to bring about and change lives and save lives. I want to welcome our guest speakers this evening, each of whom will speak briefly about why this issue matters and what each of you must pay attention to now and after the COVID-19 crisis is behind us. We'll begin with Marc Morial, President of the National Urban League. Marc?
Thank you. Can you hear me?
Yes, we can hear you.
Fantastic. Let me very quickly thank you, Judy, and the Urban League of Louisiana for hosting this informational webinar tonight. I'm also proud to join Mitch Landrew, Sharon, Weston, Broome, Dr. Jennifer Avegno, Councilmember Jason Williams, Councilman Jay Banks, and my good friend, former council member and WBOK radio host, Alda Thomas, who will be speaking tonight. And I want to thank each of them for their outstanding leadership and friendship over the years. And Judy, to you and the Urban League of Louisiana for staying the course, for keeping it real, for leading the community. My prayers and thoughts are with my beloved hometown of New Orleans, my beloved home state of Louisiana, with the challenges that have occurred with COVID-19. The untimely and unfortunate deaths of many people who are friends and family members and people with whom many of us have worked and dealt and shared with over the years strikes definitely at our hearts. And the challenges that the community faces today are part of this now global pandemic. And I stress global pandemic because to me, this is tantamount to World War III. This is an uncertain enemy, an enemy which has taken 25,000 lives here in the United States, far more than Hurricane Katrina, Hurricane Rita, and 9/11 combined, along with Pearl Harbor. The three of those combined did not cost us as many lives as this COVID-19 in less than 60 to 75 days. But it's a time when all of us must lead. All of us must heed. We must lead and we must heed. We must heed the exhortation, the instruction, the messages to physically distance and stay at home. And we certainly, for those who are first responders and essential employees, we hope that every step will be taken to keep you and yours safe, as well as for all of the frontline healthcare workers. I will say this, and I want to say three things. The first is that the Urban League of Louisiana and the Urban League across the nation, all 90 locations, are part of the first line economic first responders to assist people who are unemployed in surviving this crisis, to assist families and communities in navigating the benefits that have been passed by the government. We are economic first responders, and we're going to be there for the community throughout. The second part is that we are not surprised that health disparities have bubbled up to the forefront. It's remarkable that in the early days of this pandemic, there were even some voices who said that African Americans are somehow immune to this pandemic. When I heard that, I thought it was garbage and fake news and a misrepresentation. And then the great British actor Idris Elba contracted COVID-19 and did an op-ed and said, people, black people, you can be affected too. So this pandemic affects all people, but it's disproportionate in its impact on communities of color. Coming out of this, we have to make a new determination to rebuild the public health systems in America, and to do it in a way that doesn't preserve the inequities of the past, but to do it in a way that reforms the inequities of the past. That's a big job, and that's an important job. And I know, Judy, you'll be on the front line. I know Mitch, Sharon, Jennifer, Jason, Jay, and Oliver, you will be on the front lines in that fight. I know that everyone listening is going to be in the front lines in that fight. And tonight, I'm sure there'll be a discussion about that, an important conversation about that. And that is a conversation that needs to take place in New Orleans, in Louisiana, but most critically at the national level, because we now see Chicago, we now see Detroit, we now see Houston, of course here in New York City, the impact has been devastating. All across the board, we must turn to each other and support each other. And we must, and we will get beyond it. So, Judy, thank you very much for the chance to speak this afternoon, and continual thanks for your great leadership on this issue and on many others. Thank you.
Thank you so much, Marc. We are so grateful that you were able to take time out of your busy schedule to be with us. Next, we will hear from Mitch Landrieu, who is the president and founder of E Pluribus Unum.
Judy, thank you. And Marc, thank you so much for all of those kind comments. Our fellow mayor, who was a great leader for so many years in the city and is now leading the National Urban League. And Judy, thank you for your leadership in LPHI, as well as to all of my other fellow speakers, brothers and sisters in arms. I really appreciate you taking the time to be with us today. Marc made a lot of really important points that I won't go back over. I adopt all of his comments in whole about what the breadth and the depth of this tragedy is. I would only add a couple of different comments that I think are worth noting. And I think the folks in Louisiana certainly know this after Katrina and Rita and Ike and Gustav and the national recession and the BP oil spill and all the other things that we have been through, that we know as well as anybody in the world that disasters really only magnify what already is. And the virus is putting a magnifying glass on these deep structural inequities that have been with us for a very, very long period of time. Our country, in my opinion, and in the opinion of E Pluribus Unum, was divided by design. And those divisions create significant disparities in outcomes that will be much more visible from COVID-19. We have to speak the truth about this. In a pandemic, we think that no information is misinformation. And that's why EPU, along with other organizations, believe really strongly that we need to disaggregate racial testing data. And we have to make sure that we're collecting the right data appropriately so that policymakers have it, so they can see in clear numbers based on the facts what we already know. We already know that African Americans disproportionately are going to suffer because of this and because of underlying health conditions that are the result of inequities that have been with us for a long time. Mayor Morial talked about something that's really important. When this is over, to the extent that it ever really will be in its immediacy, we will continue to struggle with things that have been with us forever. And as we try to build back all of the institutions in America, all of which have to be built back, we cannot build them back like they were. We have to build them back the way they were supposed to be if we would have gotten them right the first time. And I think that we have to spend a lot of time really speaking truth to power in a way where the public can again come to terms with what it is that was there before COVID hit and why the African American community and others are so disproportionately devastated by its impact. So I stand shoulder to shoulder with all of you, as does E Pluribus Unum. Our report, Divided by Design, which we put out in October, unfortunately, was somewhat prescient. But as Mayor Morial said, it should not really have been that much of a surprise. It's just horribly unfortunate, and it's something that we think the country can't look away from. So I look forward to, sharing with all of you the burden and the responsibility of making it right. Judy, thank you so much.
Thank you, Mayor Landrieu. Thank you for being with us and for the work that you're doing with E Pluribus Unum. Our next speaker is Sharon Weston Broome. She is the Mayor President of the beautiful city of Baton Rouge, Louisiana. Mayor Broome.
Good evening, everyone, and thank you, Judy, and thank you to the Public Health Institute as well for hosting this town hall meeting, and to my friends and colleagues. It is a delight to be on this very important Tele-Town Hall with you. I do believe that our comments you'll find a very common theme in what we are all saying, from my friend Marc Morial to Mitch Landrieu. This coronavirus has presented unprecedented challenges to every sector of our community, our neighbors, our friends, loved ones. They've all experienced some very significant changes in their daily lives as a result of their health concerns and economic concerns, and the efforts we are all talking about that this pandemic is spreading across the country. We have seen the coronavirus pandemic has, as many have said already, put a spotlight on social and racial inequities that we already know existed in our community, in the African American community. Recently, it was stated that 70% of people who have died by COVID-19 in Louisiana are African Americans. As of today, the ratio has dropped slightly to 59%, but that is still a huge and unacceptable disparity. So when we begin to look at the impacts of COVID-19 on the African American community, we must look at the social determinants of health, which are all the factors that lead to someone's health outcomes. Now more than ever before, our community must have a whole health perspective as we work to address these inequalities. When it comes to health, socioeconomics, education, crime, and the zip code where you live, as you know, are just as important as your genetic makeup. And so these social determinants of health also play a very significant role in our mental health outcomes as well. And we know African Americans have a disproportionately higher rate of the underlying health conditions known to make individuals more vulnerable to COVID-19. And we've long known these issues not only exist in Baton Rouge, but across Louisiana and across the United States. And so we have been working to look at these disparities in our office through our Mayor's Healthy City initiative. I know when we finish and work through this, we will certainly have even broader discussions around health disparities, shaping policies, whether it has to do with making sure people are paid equally, that they have a livable wage, or other policy issues to help us stand up during a crisis like this. We've been fortunate here in Baton Rouge that we had already done a community health needs assessment and joint implementation process that help us foster an alignment across those different sectors of community development and health and housing. So and employment as well. So we will continue to look at those issues moving forward. And certainly we know that these conversations, like the ones we're having tonight, are critical in making sure that as we move forward, that we are addressing the issues that will move us beyond the crisis of COVID-19 to a safe and healthier community, city, and state as well. And so I want to thank you all the experts who are on the call, many of who I have spoken with personally, for all the input and meaningful insight you're offering to us as we move forward from COVID-19.
Thank you so much, Mayor Broome. We are so grateful to you for being with us this evening. Mayor Latoya Cantrell, unfortunately, could not be with us this evening. She sends her regards, but she also sends one of her partners standing shoulder to shoulder with her against the COVID-19 virus of the city of New Orleans. Dr. Jennifer Avegno is with us. She is the director of the City of New Orleans Health Department. Dr. Avegno? So I think I just got a message. Mayor Cantrell did a press conference late this afternoon. Dr. Avegno was with her, of course, at that press conference, and she may still be meeting with Mayor Cantrell. So we will move on to hear from Councilmember-At-Large, Council President Jason Rogers Williams with the New Orleans City Council.
Thank you, Judy, and thank you to the folks on the call that have served and led in the past and sacrificed, and thank you to those that are sacrificing now. This meaningful discussion is more poignant than it has ever been. Over the past week, media headlines have been filled with reports about the disproportionate impacts of COVID-19 on Black Americans. What is disturbing to me are the so-called learned or seemingly learned journalists that are using titles like, "Why is this happening?" These outcomes should not be surprising to anyone, but they certainly shouldn't be surprising to learned journalists. And it's frankly irresponsible when these journalists and certain leaders react to this data with surprise or confusion. Betsy, Katrina, and now COVID-19 are just exposing readily apparent disparities that all of us see every day as we walk and drive and live in the city. Much of the current conversation on this topic, which is even equally disturbing to me, suggests that somehow the fatality rates among the Black community are largely the result of lifestyle choices, of just the choices that the Black community makes. And this line of thinking is wrongheaded, it is dangerous, and it denies so much of our past. In fact, health reports dating back at least back into 1906 acknowledged that the impacts of societal inequities on sickness and on death rates in the Black community, we are not that far removed from a time when Black men and women did not have a choice over their bodies, over where they ate, over how hard they had to work. Poverty is linked to poor health outcomes, historic racism around housing, around education, around employment, and it has continued to lead to a persistent racial wealth gap that has even grown more so during this current administration. History has shown repeatedly that in times of crisis, any time of crisis, whether it's the Great Depression or any other hurricane or any other devastation like this, those with the least get hit the hardest. Stress, fresh food deserts, the lack of access to preventative care and early intervention, jobs that don't give you the choice or the privilege of calling in sick or working from home. And not just the lack of money, but the lack of time to focus on your body's needs, to focus on your body's changes. These are not choices, but these are circumstances that contribute to poor health. The economic fallout from the coronavirus pandemic is only going to compound these stresses even more. And although we're talking about the impact of health outcomes on Black America, I think it is also important that we talk about the trauma and the mental health impacts that will certainly be had by young people who may be strong enough, who may have an immune system to battle this infection. They will not have the defenses necessary to battle the trauma that this particular disease is causing. Because as we have lost community members, as we have all lost family members to this thing, we are forced to do what is counterintuitive to New Orleanians, counterintuitive to Black Americans. We cannot bond together and celebrate those losses and mourn those losses, and nor can we stand with people while they're dying. So I certainly would say the same thing that I've said to many during Katrina and after, that we are going to have to pay the cost of not dealing with the trauma in our young people who lived through Katrina. And we need to also, as we have this conversation around disparities in health, have a conversation about disparities in mental health access and the certain impact that this will have on the minds of young, on us all, frankly. So as we work our way through this, I think it is important that we extract commitments from national leaders to make sure that persons like Dr. Fauci and other experts in their fields, whether it's housing, whether it's education, that we stay on focus on dealing with these impacts as we prepare for the next wave of COVID-19, which will certainly come, and for the next pandemic, which we certainly have to be prepared for. And the only way that we can certainly do that is to use all of the data that certainly exists as we look towards rectifying the sins of America's past. And the fact that we have not done that truly is a reason why we are having the outcomes that we're having in our community. And I thank you, Judy, for
Thank you so much, Councilmember Williams, for those very important remarks. We appreciate you taking the time to be with us. I believe Dr. Jennifer Avegno, Health Department Director for the City of New Orleans, is now with us. Dr. Avegno? I think we're having trouble with Dr. Avegno being able to link in to us. I'd now like to go to Jay Banks, who is the New Orleans City Council person for District B. Councilman Banks.
Hi, good afternoon, and thank you for hosting this, and thank all of you all for participating. You know, it's not hard to add 1 and 1 and get 2. And when you put together the reality that many people in our community live in food deserts, live in situations that does not lend itself to having the best health, it's no wonder why this COVID pandemic is affecting us so adversely. You know, there are places you can go right now and you can't get a fresh apple, but you can get a 40 ounce. You can't get a head of lettuce, but you can get a pack of cigarettes. It's not hard to get from point A to point B when you've got that kind of reality that people have to live with every day. And this whole economic disparity spectrum that we're on not only includes money, but it includes health, access to health, and all of the other things that accompany living every day, living conditions and everything else. So it's not hard to see why we where we are. Now, the good news about this thing is that typically when New Orleans gets tagged with something bad, like a hurricane or the levees breaking, it's just us. This, however, is international, but more importantly, it is national, which says that people around the country have to be seeing this in the same set of eyes that we are seeing it in the game. Typically, when a levee break here, it's just us looking at it. But now everybody has to look at this, and everybody has to acknowledge that this disparity is real. Now, I don't think that God makes mistakes, and I think that this thing is happening when it's happening for a reason. We are smack in the middle of a presidential election. Neither party or neither candidate, anybody else that's in any kind of power is going to be able to run from this. These issues have to be addressed and have to be addressed with a long-term solution. See, that solution is also not just helping us get past the medical crisis of this pandemic, but it also has to incorporate the economic disaster that's going to take place after the medical crisis passes. You see, when this economy kicks back in, we were successful here in New Orleans in getting Entergy and Sewage and Water Board to stand down on disconnects or non-payment of bills, but that's not going to last forever. We were successful in getting getting the courts not to evict anybody for not paying rent, but that's not going to last forever. What's going to happen is when the economy does start up, all those chickens are going to come home to roost. We've got to be intentional in understanding that the second pandemic, it's an economic pandemic, is coming. So I'm very happy to be a part of this conversation with all these very, very, very learned minds on this call, because this is twofold. And it is going to be long-term. This medical crisis will pass. But the long-term economic issues that cause it to be as bad on us, they have to be addressed. And they've got to be addressed intentionally. We cannot just kick this down the road anymore. And with everybody across the country now seeing it, I'm hoping that we can get some things done. Thank you.
Thank you so much, Councilmember Banks. We will try Dr. Jennifer Avegno one more time. She has been trying to get to us and she wants to speak to everyone. Dr. Avegno, are you with us?
Yes, Judy, can you hear me?
Yes, we can hear you.
Wonderful. Okay, thank you. I apologize. I'm so grateful to be here. Thank you for the opportunity. I'm calling you right now from the emergency department at University Medical Center, which might explain some of the technical difficulties, but also allows me to speak a little bit to what it's like at ground zero. I am an emergency physician by training. I had the privilege to learn and to work at Charity Hospital. And any of us who practice medicine or are a healthcare worker in the city of New Orleans, we have known that there have been health inequities for generations and indeed for centuries. And for anyone to think otherwise or to expect that this virus would not affect our citizens of color disproportionately, I think they just weren't paying attention or didn't want to pay attention. You know, at the health department, this is also something that has been forefront for many, many years. We recently, like Mayor Broome in Baton Rouge, we recently published our most recent community health assessment, in which on every measure of health outcomes, African Americans were at higher risk. So this is something that we have known, we have talked about for many, many years, and it is exactly the same COVID. You know, as was said earlier, what we know now is that 60 to 70% of our deaths have been of African Americans in this virus. And yes, there is a significant association with chronic medical conditions like diabetes, like heart disease, like kidney disease. But make no mistake about it, structural racism is an independent risk factor in this disease, just as it is in many of our other outcomes. And I think the more that we can say that and have conversations about it, the more that we can do something about it. And that's why when we plan our recovery, we have to be deliberate and intentional. It took hundreds of years of intentional policies to create these outcomes. And now we have to be deliberate about how we reverse them. And so that's why when we think about, when we emerge from this, who should go back to work first? Whose health should be prioritized? Who should get tested? Who should get antibody tested? Who should be the first line? We have to be incredibly intentional about making sure it's our African American residents whose economic circumstances, as Councilmember Williams alluded to, leave them the most vulnerable. It's those workers that before now never had paid sick leave or are making minimum wage or did not have access to the same health insurance. And so that's why what the health department, with the city's focus, as I know are other cities around the country, or at least I hope, it is to prioritize the health and the needs of our citizens and friends and neighbors who are most vulnerable to this, and that is our African American residents. So I appreciate you giving me the opportunity to speak, and I'm so grateful that there are so many leaders thinking about this and committed to this.
Thank you so much, Dr. Avegno, for being with us, and we're grateful to you as a health professional for your leadership. We will now go to Oliver Thomas, who is a trusted and valued community leader and voice for the community. He's also the radio host of OT in the Morning on WBOK AM in the beautiful city of New Orleans. OT?
First of all, good evening. I want to
We may be having some challenges with hearing from Oliver. So we will try to bring Oliver in again a little bit later in the town hall. Let's now go to Gerrelda Davis, who is the Chief Executive Officer for the Louisiana Public Health Institute. And Celina will give some brief remarks and lead us into our panel of health experts. Celina?
Awesome. Thanks so much, Judy. Can you hear me okay?
Yes, can hear you fine.
Awesome. And thanks so much for all the leaders who shared earlier. Good evening. I'm Gerrelda Davis, the CEO of the Louisiana Public Health Institute, a statewide public health institute really committed to ensuring all Louisianans have an opportunity to be healthy and well. And I'm so honored and grateful to have the opportunity to moderate this panel of leaders and colleagues. You know, we've heard so much information already, and I think this is a nice segue to the next phase of our conversation. You know, as everybody shared previously, you know, last week, the Louisiana Department of Health released their race ethnicity data for people who have died due to COVID-19 related complications. You know, and today we continue to see disproportionately higher rates among African Americans. You know, of the roughly over 1,000 deaths reported today, 60% were African American, while 30% were white American. And to kind of put that in perspective, African Americans make up about 32% of our state's population. So over the next 40 or so minutes, you know, we'll hear from 9 leaders from public health to academia to healthcare, clinical practice. You know, each will share, frankly, from their perspective, factors that contribute to health inequities in our African American community, including, you know, really exposing structural and systemic racism that is interwoven into the fabric of our society. They will also offer up some insights that speak to the importance of whole health, that's physical, mental, and spiritual, and offer up some calls to action. So without further ado, our first 2 panelists are representing the Louisiana Department of Health. And I'm going to start first with Dr. Alexander Billioux, the Assistant Secretary of Public Health. So Alex, I'll pose the questions, but if you want to pop up on the webcam. You know, as the Assistant Secretary of Health, of Public Health, a physician and leader who is committed to health equity, can you share your insights into why these disparities persist and what the state of Louisiana is doing about them?
Absolutely. Thanks, Celina, and thanks, Judy, for having me on. You know, I think following such great speakers and thinkers and leaders, what I have to say is really going to largely echo what you've already heard. You know, I think at face value and at the most superficial level, we know that one of the reasons that we're seeing people, African Americans specifically, have more challenges with COVID-19, and to be clear, dying at higher rates, disproportionately higher rates, is because of the underlying conditions that are present, whether that's high blood pressure, diabetes, obesity, kidney disease. These all sort of run together. And you know, that's one of the reasons that we believe we're seeing higher levels of mortality in that community. But again, as you've heard every speaker say, and as I'm going to emphasize, I think we have to keep digging deeper below that. And if we dig one layer below that, we know that the reason that the African American community has higher levels of hypertension, diabetes, obesity is because of not only a lack of access to healthcare, certainly before Medicaid expansion, but even challenges post-Medicaid expansion, as well as challenges with access to the health-related social needs that individuals need to be healthy and stay healthy. Lack of access to stable housing, lack of access to healthy foods, transportation, lack of access to a living wage. Those things limit the ability of an individual to actually take preventative steps to keep their health in the first place. And certainly once you have a chronic condition like high blood pressure or diabetes, those challenges, those barriers make it harder to manage those conditions and put you at greater risk of having more fragile or more poorly controlled, say, diabetes or high blood pressure. And then we think that that's one of the things that we're seeing with worse outcomes with COVID-19. But again, we can't stop there. We need to dig a layer deeper than that. And again, as many have echoed on this call, what underlies the challenges that the African American community faces in having access to employment, having access to stable housing and food? And really, it comes down to racism, generational, institutional, and personal racism. And I think, you know, the barriers that are put in front of the community, the challenges for individuals to be able to actually avail themselves of those things that enable them to stay healthy, the ability, as Councilmember Williams said, to be able to stay home and be able to steer clear of COVID. All of those things are hampered by generational and still very true racism. And so I think that the challenge before us in the department and certainly at the state level is sort of acting very quickly in both near-term measures and then longer term to address these issues. I think in the midst of a COVID crisis, we're laser focused on the things we need to do to try to prevent death. And specifically in this case, to especially prevent death in the African American community, because we know by our estimates, they may be twice more likely to die from COVID-19. So that means focusing on first getting testing out to communities that are not adequately being tested right now. We are proud of the fact that Louisiana is #1 in per capita testing. We are testing more people per 100,000 population than the state of New York, than the state of California, than our neighbor Texas with 7 times our population. But we also know that that testing is not uniformly distributed. We are not getting the same information about communities of color and giving them that information about their health that we're seeing in other high population density areas. And so we need to make sure that we're expanding that testing to empower communities to be able to respond and to join us in trying to mitigate the spread of the virus. 2, we need better access to healthcare. Again, we are fortunate that Governor Edwards did expand Medicaid, and with the guidance and leadership of Secretary Gee during her tenure, really made dramatic inroads in trying to address the racial disparities that our 2-class healthcare system had when we were reliant on charity care. But that still is not going to be enough. We also need to focus on prevention. How can we now improve prevention for those communities? How can we enable people to stay at home, to do so without worrying about their livelihood, without worrying about their ability to feed their families, to stay in their apartments, to keep their lights on. We've certainly had some relief from the federal government in those respects, and certainly strong actions taken by Governor Edwards and the administration. But again, as Councilmember Williams said, what happens after? What are the next steps? And so I think in the longer term, what we're doing from within the Office of Public Health in partnership with Dr. Benjamin, who you'll hear from in a moment, is really thinking about how do we take this near-term focus on an issue that is not new in any stretch of the imagination, and use that focus and frankly the resources that are flowing towards this problem to build long-term strategies to address the long-term health inequities, to address the racism built into our systems, to reverse those so that we're not in the same position talking about the next pandemic and frankly the next storm in our future, because I think this conversation happens not infrequently. And so really I think putting conversations like this at the forefront, putting leaders like those on this call at the forefront, and making sure that as we see the curve flattening, as we improve our management of COVID-19, that doesn't take the pressure off the dire nature of this inequity and the Black deaths that are happening. If it wasn't COVID, it would be stroke and heart attack that we should be talking about. It should be the fact that we're talking about, though as a state, we have one of the lowest life expectancies, African Americans still have 4 years less than their white counterparts. And we need to make sure that what we're building now really addresses not only what we're dealing with now, but the long-term challenges.
Thanks so much, Dr. Billioux. And now we'll have up next Dr. Earl Nupsius Benjamin Robinson, who's the Deputy Director of the Office of Health Equity Community Partnerships. So Dr. Benjamin Robinson, you know, your team, as Dr. Billioux alluded to, is spearheading the Health Equity Plan for LDH. Can you share how this plan helps to change the narrative around disparities, and what call to action can you offer to change this narrative?
Thank you so much for having me, Celina. It changes the narrative because it gives us an opportunity to operationalize plans around what can be done to help improve the health and health outcomes of the people that we serve. Typically, when you look around the nation, when you look at health equity plans, you'll find robust, obtuse health equity plans that say this is going to happen and that is going to happen. But inside the state of Louisiana, leadership has given us, my office, the liberty to create a plan that is centered in doing very, very specific protocols and activities inside each office inside the Louisiana Department of Health. So I came into LDH last year under the leadership of Dr. Gee, and in that time I had, my staff and I had about a 12-month period to create a solid plan that looked at, one, the culture of LDH, and two, how we could incorporate what LDH was doing successfully as it relates to health equity, and what we could do or borrow from other states and our health departments around health equity. And the first thing that we were able to do was to create a barriers to health fact sheet. And on this fact sheet, what we did is we acknowledged that there were institutional and structural inequities that existed and contributed to the health and health outcomes of the people that we serve. And we analyzed data and determined that there were some very specific things that each office inside LDH could be working, well, not necessarily working on, but could include inside the interventions and messaging that they did inside the organization. And so whether you were working on HIV, whether you were working on obesity, whether you're working on tobacco, all of the offices have a need, given the fact that not only is data important to the health and health outcomes of knowing what data means is important to the health and outcomes of the people that we serve, but knowing what's going on inside their communities is important. And so one of the things that we initially created in this process is the barriers to health fact sheet. And we created this document because it helped to identify what each office could be doing, how each office could be leveraging these activities into their respective work, no matter what it is that they were doing. And so some of these things that we, and again, this process is still, it was about to be implemented before COVID-19 happened, but it supports each office in being able to partner with community-based interventions. It will support offices to improve program collaborations related to sustaining housing efforts, food security, job, employment, GED. It is not that it will be the responsibility of the health department to do these things, but we need to identify these assets that exist inside the community because it's more than, it's about the community. It's about understanding what the assets are that exist inside the communities. And so this document, it will be an educational document that is used to educate individuals that work inside LDH on the possibilities of collaborations that they can be involved in inside LDH to do their work. We need to go beyond just saying, hey, if I'm talking about obesity, I need to give a pamphlet, or we need to create a walking trail. There are a multitude of factors that affect obesity, and it's important that we understand those factors and we use those factors to develop programming that is real-time, specific, and can ultimately help us in improving the lives of those individuals that we're serving. And so that was one of the first documents that was created out of it. Again, the significance of the barriers to health fact sheet is just to build our staff's understanding of what are the factors that need to be considered when developing a public health program and our message. The other component, the most important component of our health equity plan is the development of the health equity action teams. These are teams that will be in all offices inside Louisiana Department of Health offices. And these teams are responsible for, one, looking at data on a consistent basis and making real-time decisions about that data. Also, looking at environmental factors in relationship to that data. Again, what's happening here is we're reiterating the importance of knowing what is going on inside the environments of the people that we serve. As an 18-year public health practitioner, one thing I have come to understand is that we all have different experiences in the communities in which we live. Those experiences need to be a part of the conversations had inside LDH with the individuals that are creating public health programs. And so the health equity action teams provide us an opportunity to, on an ongoing basis, examine data consistently. This doesn't necessarily happen all the time when programs are getting made. And that happens across the country, but the health equity action teams will provide an opportunity for data to be looked at on a consistent basis, and then provide guidance for those teams to also be assessing what's going on inside those environments and using that information to inform the work that is being done inside that office in a real-time fashion. Some of this was already being done inside some of the bureaus inside LDH, like the Bureau of Infectious Disease and the Bureau of Family Health. And what we are doing inside LDH's Health Equity Plan is raising those activities to the level that all offices inside LDH are operating from that perspective, are using data on a consistent basis, are thinking about the environments that people come from, so that all of that information informs the work that they do. And so it helps us to make certain that we are creating real, effective programming and services and messaging that take into consideration not just the data as it relates to the health, but also the environments of the individuals that we're serving, so that we can better develop programming and services.
Thank you so much, Dr. Benjamin Robinson. Next up, we'll have Dr. Denise Shervington, President of the Institute of Women and Ethnic Studies and Chair of Psychiatry at Charles R. Drew University. And Dr. Shervington, as you're pulling your webcam up, if you'd like, the question that we have for you, we know that it's really important, as we've been hearing from many panelists, to understand the whole history of African Americans and how this has impacted our health outcomes today. From your perspective as a psychiatrist and head of a community-based public health institute, can you please share your insights on what whole healing looks like, and also looking back at the historical perspective, as well as offer up any call to actions to shift this narrative?
Certainly. I would like to thank you, Celina and Judy, two of my colleagues, amazingly powerful leaders in the city. Thank you so much for having me. And I want to acknowledge the wisdom of those who spoke before and those to come, my fellow panelists. Lest we forget, America has a very tainted history of structural and individual level racism that has harmed our communities. This devaluing of our life began during slavery and continues through today. From the beginning, the healthcare industry and practitioners have been major participants in perpetuating white supremacy. I just give a few examples. Samuel Cartwright, a physician who was here in New Orleans in the 1850s, who coined the mental illness drapetomania for runaway slaves seeking freedom. He also, to the Medical Society of Louisiana, stated that our respiration was imperfect and our blood imperfectly vitalized. Marion Sims, who has been called the father of OBGYN, operated on Black slave women in Alabama between 1845 and 1849 without consent or anesthesia because he thought we did not feel pain. And he was trying to perfect his skills in repairing vesicovaginal fissures in white women. Many of us remember Tuskegee from 1932 to 1972. 400 sharecroppers in Alabama were refused access to life-saving drugs, penicillin. And what was worse, that at the congressional hearing in 1972, it was stated by the US Public Health Service that the doctors and civil servants were doing their duty for the glory of science. They did not accept responsibility. Charles R. Drew, where I do some work now, inventor of storing blood plasma in blood banks, he resigned his post as the chief and lead doctor for the US and British armies during World War II in protest of their policy that Black blood had to be stored separately from white blood. And currently, the widely held belief that Blacks don't experience pain as do white people, that our blood clots more easily, and that we feel less pain. The repeated studies where we do not receive the pain medications, they're underutilized again, thinking that we don't experience pain. And I just want to highlight Dr. David Williams, a Black sociologist at Harvard, who has repeatedly argued that the underpinning of health disparities is the complex interplay of racism and socioeconomics, not underlying genetics due to race. So what do we do? And I'm glad so many who have gone before me have talked about racism in America. So now that we're naming it and we are talking about it, we're also going to have to undo it. We cannot continue to have this virus in our lives. We have to understand how racism has shaped the narratives about us under the construct of health disparities. And we're going to have to begin, as someone said earlier, center at the margins. We have to give voice and change the narrative, give the power to those who are voiceless, disempowered, and unable to advocate for themselves. And this comes when we value the lives and well-being of all people. We recognize and rectify historical injustices that shape our health. And we provide the needed resources according to need, not privilege. And as we continue to fight to free ourselves from the boots around our neck that have created damage, I think that it is really important for us leaders, health leaders in the community, especially our mental health leaders, to share with our community that it's not our fault that other humans were evil and unjust and have created these adversities. But it is our responsibility, those of us who've survived, to heal those wounds. We have to also acknowledge there is a lot of resilience fatigue in our community. And so rather than keep asking us to keep being strong, how about help us manage our vulnerability? We have to get out in front of our community and denormalize trauma. It's not normal and we don't need to keep it moving. Help our community to work through the pain. Help our community to destigmatize the sometimes warranted distrust of our system, but to work with it as best we can to make it work for us. There's also a lot of wisdom in and indigenous healing practices. We need to lift those up for ourselves. And I think ultimately we have to respect whatever our traditions that help us to work through the pain, the spiritual aspect of ourselves that help us to interrogate the mystery and deeply ponder what is the meaning, why are we here, and how do we work through our journey in life. Thank you very much. And I hope I kept to my 5 minutes.
You're good. Thank you so much, Dr. Shervington.
Yes,
All right, so we're going to move.
Of our medical students to show that there's hope.
Awesome. Thank you so much. So we're going to shift a bit to our folks in academia. We're going to start first with Dr. Rebekah Gee, who's the Chief Executive Officer at the Louisiana State University Healthcare Services Division. Dr. Gee, as a former State Health Secretary, as was named earlier, and an OB-GYN physician committed to equity, I saw the letter that you wrote to the editor last week. You and President Barrett offered a plea for all workers to be protected, which obviously, intersects into this conversation. So can you share your insights into why this is so important and how we can change the narrative around African-American health disparities in this community?
Yes, thanks. Thank you, Celina. Thank you, Dr. Shervington, and other members of the panel. I just wanted to reflect quickly on my journey through state government over the last 10 years, and just to reflect on the powerful words we just heard. I mean, 10 years ago, when I first started as running the Birth Outcomes Initiative for the Jindal administration, I was first told that we couldn't show data by race because racism didn't exist. And then when I asked to have a panel on racism, where just a brown bag where we could have a discussion at the health department, I was told that I was a Yankee, even though I'm from Utah originally, but that I didn't understand the South and that racism doesn't exist here. And I was told by senior leaders of the health department staff that we could not have a discussion about racism, period, that we could not show data by race at all. I'm proud of the progress we've made, but it's only the beginning. You heard from Dr. Benjamin Robinson. I'm very proud of having the Office of Health Equity, the first at the health department. However, there were many people who told me, and I think folks listening who were with me at the health department at the time will remember this, that health equity wasn't something we should really talk about. It wasn't politically correct. We shouldn't really broadcast that we had this, and we should just kind of keep it quiet, which was unbelievable. So what we did was the opposite, and we broadcast, and as you heard about our HEAT teams, we developed not just an acknowledgement of the impact of race on health, but actual plans to address in every aspect of the health department, as well as to make or to require senior leaders to do an assessment of their own attitudes and biases and how those would impact their ability to make decisions. So it's only a beginning, but I'm very proud of this work and glad it's continuing. In terms of our essential workers, it's something that Dr. Bray and I wrote about last week. I'm very concerned about issues of health equity for them. My concern started several weeks ago when I was in a pharmacy talking to someone. The person had no mask whatsoever, no protection, and just really started to think about this issue in our essential workers who frankly are being treated like they're disposable workers. These individuals have, now going on several weeks into the epidemic, no protection, no education on how to protect themselves. And as a result, I think unfortunately we've seen already preventable deaths, and these deaths happen disproportionately to members of the community who are people of color because they have disproportionately lower, because of all the reasons that have been discussed earlier, are disproportionately in jobs that are lower paying and disproportionately are in jobs that they cannot work at home, which is frankly a great leisure. It's great that people can do it, but these are mostly folks who are higher socioeconomic status, the lawyers and other professionals who have the luxury of working from home. And so we really need to protect our essential frontline workers, and they are just as essential to the functioning of society, I would argue, as many of our healthcare team, people that bag your groceries, people that have an impact on whether you get medication or not at a pharmacy or essentials are important. If they don't work, we can't function as a society, and they need to be protected. And so I think it's way past time to have national standards of workplace safety. It's way past time for every single person in an essential job. I like our bus drivers, and I think you might have read the story this week where we had 3 RTA bus drivers die, and 1 in 8 were impacted and infected by this virus. That's totally unacceptable. Time has passed, and we need now to have workplace safety. So I've been contacting firms like Walmart, CVS, and so on, and still I think the action is slow. We need to demand change now. Number 1. I think number 2, what this is highlighting for folks are 2 key issues. One is that childcare is not just a woman's issue. Childcare is an issue that society needs to address. I think another very important issue, and why we're having disproportionate burden in families of color, is that there is not affordable childcare in America, and certainly not in Louisiana. And people have to then use older parents and folks to watch their kids, and they're doing essential jobs without protection, and then coming home and exposing older generations to this virus, I think, which is contributing to some of the disparities we're seeing. We also realize, for those, I'm very proud of our record on Medicaid expansion, very excited about the fact that we have lower uninsurance rates in this state than ever in its history. But there are a lot of people that don't believe that healthcare is a human right. I happen to believe that. But I hope that the American people now are a little bit more woke on the fact that the health of one individual can impact the health of an entire community. And if we don't cover people with healthcare, if we don't provide for their basic needs, they are at risk for being sick and also infecting other members of the community. And so we've got to have a national healthcare system that covers everyone. We've got to take care of each other and invest in public health, ensure paid family leave, ensure paid sick leave. Because if we don't address these things as we deal with this epidemic, we are not going to solve this problem, and we're going to have a difficult time addressing some of the underlying reasons why people get sick. Finally, I just want to say I'm excited to be at LSU and proud that we are committed to caring for everyone, regardless of the ability to pay. And this month through K Health, which you can download on Google Play or Apple app, you can get an app or lsu.khealth.ai for free primary care for the month of April. We don't want the ability to pay to be an impediment for anyone in our state, and we hope that it gets used. Again, I think this epidemic reminds us that healthcare is a right, that we need to invest in it, and shame on us as a country for disinvesting in public health, for disinvesting in healthcare, to those governors in those states who have denied healthcare to their people, because they will see greater challenges and unfortunately higher death rates because of these policies and neglecting the health and the investments. And I think you can see in the comments of Dr. Billioux and others, we have some phenomenal assets in this state. We do have a good public health reporting system, and we did have a governor who was one of the first in the nation to acknowledge the disparities and to continue to have a commitment to addressing them. So that's not the solution, but that's a start, and I'm glad that we're at least there. So thank you for sharing some time with me.
Thanks so much, Dr. Gee. And now we'll move on to President Verret, president of Xavier University, my alma mater. So Dr. Verret, as the president of the university and HBCU, an expert in enhancing quality and diversity in academics, can you share why it's so important for us to address these disparities and discuss maybe some ways Xavier's doing that?
Well, only briefly about Xavier, because we know that Xavier, we educate young people who become physicians more so than any university in the country, as far as Americans who become physicians, but also pharmacists and other health professionals. What we do is important to keep to diversify healthcare and make sure that we have available to our people practitioners who look like themselves within the large enterprise of healthcare. That's important for what we do. But we also ask ourselves the hard question, exactly what makes a community more vulnerable to a pandemic like COVID-19 versus other communities? And the factors of that, when people have mentioned earlier the social determinants, it's important to understand that basically that robust healthcare, the practitioners like Dr. Avegno and others like themselves, what they are putting in place by in and of itself will not protect the community. It will provide great healthcare, and there's a limit to what can be accomplished, because we know that the societal factors that impact quality of care, quality and quality of health, and that protect and make and a community are also factors that are economic and social, the largest social determinants. I have taught my students many years ago that it's striking that the major hospital centers, the leading healthcare centers like Mass General or the Brigham, or you can go down to New York to Columbia Presbyterian. Those hospitals are, the people living within only a few feet of those hospitals have the least access to the benefits of those major health centers. It's because of economic and also social factors. And that applies to New Orleans even more. And so I think it is important that we look at those factors that protect the community. For example, we have to know that, for example, quality nutrition and food and supermarkets in the community affect healthcare. So to make sure that in our communities going forward that we have access to great nutrition within all communities in New Orleans and around the country is important, protecting African Americans and other people underrepresented groups like the Navajo Indians as well. It's important, for example, for us to think about the access to employment and how people travel. It's also important to understand the responsibilities that we have collectively as individuals to protect each other. For example, we don't have the legal structures as we do social determinant did not consider exactly those who could not socially distance. For example, the people who work in the supermarkets, who are on the lines of our food industries as well. It's important that we impose a legal obligation on each of us coming into those establishments to wear a mask and not leave it purely to that we have responsibility not to come and infect others. That is not was not fully considered. It has to be considered right now. I would also say that we in our communities have some power, that we may not fully control the impact of COVID-19 on our communities, but we also have some responsibilities to protect ourselves and protect each other. In other words, how we use masks, how we socially distance, and also that we do not accept and believe some of the false narratives that are being promoted in the media. For example, the notion that black people were immune is preposterous, but it has some legs on social media, and people continue believing these things. We also have both on the left and right narratives that say, for example, that the COVID-19 pandemic is a fabrication that allows governments and states to arrogate more power over people. On the left, on the right, we have the other pretext that the COVID-19 is a pretext to affect the election to suppress the election of the current president. All BS. These things come to us, and we also have to counter those narratives to understand that we have some responsibility to protect ourselves, to look for information where it is sound information, like places like the Department of Public Health, universities as well, to actually not accept what is circulated about the fake news that comes around us. Our safe communities also require that we also have equitable education. As we speak of a fundamental social determinants of health, educated communities are healthier communities. Equitable education has been one of the struggles that has not been fully realized for African Americans and other minority groups in this country. And it's not just education at the higher education level in places like Xavier, but also K through 12 education. That there are great schools and okay schools for the rest. That we have to make sure that we educate students, because those educated students will be the ones who will take us forward when we emerge from this pandemic. But also they are the ones who will be able to engage in the economy fully and be protected, because they will have the good jobs. They will be able to bring economic resources in their community. Having those resources arrogated only to parts of our society weakens the society. And we also know that it also endangers everyone, because it is not only Black people who are dying from this. Thank you.
Thanks so much, President. And now we're moving on to Dean Leveist, Dean of Tulane University School of Public Health and Tropical Medicine and professor. Hi, Dean Leveist. As we all know, this virus does not discriminate, as we've been hearing. Can you share why it's so important to understand the facts and checking our own social bias to help eliminate disparities?
Thank you for inviting me to participate in this important conversation. You know, I'm new here to Louisiana. I've only been here a year and a half and still learning a lot about this community. And I think it's important that we, I think it's important to focus on the facts, because particularly the way that this outbreak has been managed at the national level, the fact that we have not had a coordinated national strategy, and as a result, the health communications has been muddled, confused, and I think has contributed to the disparities that we see. So, for example, early on, when in the epidemic, there was talk about this epidemic really being something for elderly people, which gave the inaccurate impression that young people were somehow immune. And as a result, young people were less likely to engage in the behaviors that are necessary to control this epidemic, right? There was confusion about whether or not people should wear masks. From a scientific standpoint, there was never a reason to be confused about that. Any mask, any cheap mask, even a mask that would not stop the virus from getting through and infecting the person is better than not wearing a mask, because this is a public health issue, a public health strategy, not necessarily a medical strategy. The mask reminds people not to touch their face. It reminds people not to put their fingers in their mouth or nose. It reminds people that we're in the middle of a pandemic and that we have to practice physical distancing. So these sorts of missed opportunities, bad messaging, led African Americans, in part, there were some sources that were intentionally misleading African Americans into believing that they were immune somehow from this virus. And these sorts of messages, and the fact that we didn't have a strong, definitive voice at the national level clarifying what the correct information was, is a big part of what has produced the disparities that we see. So as an academic, as someone who spent my entire career focusing on doing research on the issue of health equity, specifically as it relates to African Americans, it's my role as a researcher to be skeptical and to be cautious before drawing any conclusions without data to support it. So, for example, a narrative that's now coming out is that the reason for the disparity by race is because African Americans have higher rates of underlying chronic conditions that we know increase the risk of death if one is infected. And that certainly is a plausible hypothesis, but at this point, it is a hypothesis. And I think we would be mistaken to simply assume that that is the reason. We also know that here in the South, and Louisiana as well as the rest of the South, that whites have very high rates of all of those chronic conditions as well. And so it wouldn't necessarily, and the disparity in those conditions between blacks and whites is not as great as some of these disparities that we're seeing in the death rates, not death rates, in deaths from the COVID virus. I'd also point out that it could be that the disparity is a disparity in who got infected. It may be there are maybe 70% of the people infected in Louisiana are African American, in which case 70% of the deaths were African Americans. That would suggest that we do have a disparity, but the disparity is not the one that we're talking about, that is deaths. Maybe the disparity is in who gets infected. And that could be the case because of the social determinants and the racism that many of my colleagues on this call have alluded to. African Americans are more likely to work in occupations where they're going to be exposed. They're less likely to have jobs that allow them to work at home and work from home on Zoom the way that I'm doing. So they're more likely to be the people who are out delivering groceries, more likely to be the people that are in the gig economy, and therefore putting themselves at risk so that the rest of us, those of us that do have jobs that would allow us to work from home, are able to do that. This is, I think, the role of the academic, is to be skeptical and to look closely at things, to identify not just the broad themes, but get into the weeds. What specifically is driving these disparities? And I'd say it's a number of things. The chronic conditions issue certainly is one of them. The fact that there are myths that were targeted to African Americans intentionally with the goal of getting them to be confused, taking advantage of the fact that African Americans in many cases have mistrust for government. And that mistrust comes from a very logical place. It comes as a result of 401 years of untrustworthy behavior. And so you put that together with the fact that we are in the region of the country that is the poorest region with fewer resources, higher rates of poverty, and therefore people who do not have the economic resources to mitigate a disease outbreak like this. It's almost in many ways a perfect storm of social, economic, structural characteristics that place African Americans at increased risk. So some of the things that we're doing at Tulane to address this is that we have just launched a new health education campaign targeted to African Americans. This campaign is titled The Skin You're In, and we have a website as well as social media channels on all of the social media networks, where we're also going to be doing street advertising throughout New Orleans, including bus wraps and other posters within communities, trying to target African Americans with accurate information that dispels the myths that have been perpetrated. We're working with federally qualified health centers here in the city to address some of the problems that they're encountering. So, for example, these clinics have now had to go to telemedicine in order to provide care for patients, and I'm talking specifically about non-COVID patients. And that's been a challenge because many of their patients have a difficult time utilizing that services. So we're working with them to innovate a solution, a program that would help people that don't have access to broadband or have difficulty accessing telemedicine on smartphones and other devices like that. We're working on a program to help them with that. We've also been talking to people in primary care here in Louisiana, and we were told that they feel that they're finding patients are coming to their clinic with atypical presentations of COVID, and ask, can we look at their data and see if we could identify other patterns in the data, that there may be other symptoms that people that they see are presenting with, and we're doing that analysis. There's a great deal of concern also about mental health and how social determinants will be exacerbated. So we can expect that there will be more food insecurity, that there'll be more housing insecurity as we go forward. And we're working with one of the federally qualified health centers to establish a mental health and social determinant surveillance system by utilizing their electronic medical records so that they can be alerted to when they will start to see spikes in some of these other needs so that they can deploy resources effectively to do that. And another thing that we've done is establish the Tulane Outbreak Daily, which is a daily compilation of information around COVID-19. This is a resource that goes out. We have people on that mailing list throughout the world who are following what we're doing there. As a Louisiana and New Orleans-based school, the first school of public health established in the United States, and a school that was founded specifically to deal with an outbreak of an infectious disease in New Orleans back in 1912. We want to be a vital part of the solution. We want to be a part of the community who is working to address the issues in New Orleans. And I've reached out to many on this call to offer our technical assistance and support as we go through this pandemic. And I'd like to make that offer again here in this forum to any organization or entity that's working to improve the health of the city of New Orleans and the state of Louisiana. We want to be a partner for you, and we want to bring our resources to help you to address that.
Thank you so much, Dean Leviste. And up next, we'll hear from voices from our provider community, and we're going to start with Dr. Rochelle Head-Dunham, who's the Executive and Medical Director of Metropolitan Human Services District. Dr. Head-Dunham, can you share your insights into why it's important for our community to take a holistic perspective that's inclusive of physical, mental, and spiritual health?
Hi, Celina, can you hear me okay?
Yes, we can.
So thank you so much for this opportunity to have this conversation. This is one of those necessary talks. We talk a lot about a lot of different things, but some things we really, really need to put out there, and we need to engage the collective wisdom of many people who have need to be brought into these conversations. And I'm so grateful that we got so many people logged in and logged on, because I have been preceded by a phenomenal panel of experts and people who have themselves developed their own opinions through their own experiences in this area. So some things that have been said, I'll just touch, and then I'll move briefly to some thoughts about what we may want to do. For sure, this is not an uncommon dialogue. The dialogue of systemic racial inequities and the impact that it has on or has had on African Americans in particular. You know, racism in and of itself is about power and an imbalance of power. And so one of the things in some of the other work that I'm doing in this space with other people around the country is asking the question of how do you upset the power dynamic in a way that people are willing to relinquish that power. Because if we can put a foot or a thumb on a group economically, which is very much the case in the African American community, if we could put a thumb on a group such as the African American community with regards to economics, that is hugely powerful in managing that group. And a lot of what we're seeing in health, mental health, the substance use sphere has a lot to do with these disparate areas of power that exist in terms of who's making the decisions about what happens to people, who decides where the money goes in order to take care of people's lives. It's certainly not the people who themselves are being disempowered and not given voice in the matter. And so I think until we can address this differential power issue, which undercoats racism, we will have difficulty in all of these areas for many more years to come. And as Dr. Shervington said so beautifully, we have a long history, and as everyone on this call acknowledges and knows so well, we have a tremendous history of disempowerment and building of power in some groups and not in others that has culminated in a number of things. I appreciate the prior speaker's discussion about data and what it means, because as I've thought through this, you know, social distancing is a no-brainer. If something is over here that's harmful to you, then you stay over there. If this is what you need to do in order to prevent your body from getting contaminated, such as washing your hands is simple. But if I live in a home with 10 people, then, you know, social distancing is not such a brilliant solution. What is my solution? Further, what is the conversation that's being had for people like me who don't have the option of isolating to a separate room in a house, which may be under 1,000 square foot large? And so it's that kind of cultural distancing that has occurred that does not even allow the right conversations to take place to even begin to address the needs of people such as African Americans. We don't have a seat at the table. I will say that when you ask the question, well, who's missing at the table? It's us. We don't have the voices we need. There are those of us, of course, many of whom are on this call, who have done well by ourselves and are operating within our spheres of control and are being influential on a small scale, some scales bigger than others. But are we able to put a dent in this very, very dense problem that goes back so far and has continuously, consistently been impactful to our population of African Americans? So one of the things that I think we really need to think about is how do we shake up this power imbalance here? Because without that, it's difficult to see the dial moving forward, except if there's personal interest involved. And some might say, well, find where the personal interest is and work that. But this level of disparity is so huge that it cannot be addressed as simply as deciding who might be interested in it for what purpose and working that angle. It is a systemic problem that is systemically impactful to us in a number of ways. To begin the dialogue, though, we can certainly begin by including more people at the table who are experiencing the problem or are culturally connected to the problem or have trusted voice in the community such that their impressions and their thoughts and their ideas about what needs to change is actually influential. because many people can have an opinion or have done research or have a narrative that they're sharing, but if I don't trust you, I really am not going to change anything that I'm doing. And so who's got a seat at the table really, really matters in this narrative. So including people who are more culturally sensitive. Secondly, working more with the communities where people live. A lot of the work we do in our world of medicine is at a level that most people never even touch. The world of research is a very closed environment. Our academic halls and corridors and classrooms, it's a very closed environment, and it's often not adequately represented by the people who we're trying to help. And so opening the doors for people who are non-traditional to have a conversation, collaborating with non-traditional partners, people of color who run organizations, who understand the children of those environments, understand mothers who have more children than they have money to feed, understand relationships that are not quite the same in the majority scenario in terms of the difficulties and the struggles. And then thirdly, increasing the workforce in such a way that we are we're supporting people who have a similar voice, have similar experiences to be a part of determining what is important to even study in our research designs. And furthermore, what is the true interpretation of this information in the context of this group? Further to Dr. Gee's point, to advocate for reporting data that really speaks to the reality of what is truly going on. And all of those things just begin to address the issue. But certainly we have to look at who's got a seat at the table, and it is not African Americans in general. And so our interest is often not best represented because frankly, we are not there. Thank you so much.
Thank you, Dr. Head-Dunham. And now we're going to move to Ms. Gerrelda Davis, the Executive Director of Louisiana Primary Care Association. If you want, oh, there you are. Hi, Ms. Davis. As the ED of a membership association of federally qualified health centers, can you share your thoughts on how FQHCs are playing a critical role to addressing these disparities?
So thank you once again for having the privilege to talk and to be on a panel with such great leaders in our community. FQHCs are critical in communities of color because they are community-based and community-driven. The Louisiana Primary Care Association represents 39 organizations throughout our state who operate over 285 delivery sites. For our makeup of people we serve, 60% are Medicaid, 8% are Medicare, 15% are private insurance, and 15% are uninsured. Our FQHC boards are comprised of majority members who seek services at the facility. This design at the high level increases the likelihood that organizations are more responsive to the needs of the community they serve. Representative of the community and decision makers are also accountable to the community. This is important for addressing disparities in African American communities because as we see with COVID-19, many of the comorbidities that put people at most risk are also some of the common chronic illnesses in the Black community. Many health centers have a targeted focus on measures to monitor and control hypertension, cholesterol, and diabetes so that patients can live fuller, more healthy lives. This includes access to wellness programs that promote lifestyle changes for those suffering with these conditions and disproportionately affects African Americans. Health centers are also able to get out culturally competent messages to their communities more easily than through other channels because they have built trusting relationships, which we know in the African American community in particular is of the utmost importance given the medical atrocities that have happened throughout our history. FQHCs provide access to primary care, behavioral health, and oral health services for those in our communities that would otherwise not have access. Medicaid increased access, but many in our communities are part-time workers, unemployed, without incomes, and are served by FQHCs regardless of ability to pay or insurance. Health centers work with patients to address the social determinants of health and are able, through patient referrals, to connect clients with community-based services that address instability in housing, food, employment, and transportation. This is important to note as FQHCs treat the most vulnerable populations, HIV and homeless populations, for example, that we have seen in recent weeks to be affected majorly by COVID-19. In addition to essential personnel, the unique staff composition of community health workers, patient navigators, and interpreters for patients with language barriers, among other roles, allow for various models of healthcare delivery, such as enabling and transportation services. FQHCs are designed to serve those where healthcare is either not available, unaffordable, both of which cause barriers to care. Our health centers are well positioned to meet patients where they are by utilizing a sliding fee scale and offering services to patients regardless of their ability to pay. Approximately 70% of Louisiana's FQHCs have patient-centered medical home recognition. This model of care aims to improve the patient experience by putting patients at the forefront of care. Our health centers provide patients with the ability to schedule before, after hours, same-day appointments, resulting in overall improved health. So what do I think needs to happen? I think we need to invest in what matters. If our citizens are our greatest asset, invest in keeping them healthy, educated, and working, no matter the race, color, or creed. Invest in what works. State government funding for programs such as FQHCs that are working. Remove barriers that only exist because of power and money. Provide full data transparencies with hospitalizations and cost and hospitals. Foster more partnerships that support the mission of FQHC to provide timely and quality access to care for the most vulnerable citizens, regardless of ability to pay. And reduce bureaucratic red tape that hinders providing quality healthcare services. We can pay for healthcare now, or we can pay for it later. We need to be proactive instead of reactive. Thank you.
Thank you so much, Ms. Davis. And now, last but certainly not least, and I know we're a little bit over time, but we're going to continue with Ms. Javon Muhammad, CEO of Southwest Louisiana Center for Health Services. So, Ms. Muhammad, can you wrap us up and kind of share what your insights and thoughts are of the importance of examining these health disparities and how we'll begin to address them one community at a time?
I can. Thank you so much for having me today, and I appreciate all the brilliance that was on the line today. I want to just take it in a little bit of a different direction, and I want to point out that in the United States, the African American is the only group, the African American group is the only group of people who have to consider another group of people in every decision that they make, and that affects our mental health. I am a midwife, and I've been a midwife for 20 years. And when I came out of school and I began to practice, I heard about the disparities in both infant and maternal mortality. In the United States, Black women lose their lives 4 times more than other women due to childbirth conditions or related conditions. And we lose our babies nearly 3 times more. And then I went to broader healthcare, and I learned about all of the disparities that we've heard about today. And as a healthcare administrator, I work with all people who have all of those disparities that we heard about today. But I want to talk a little bit about what to do about that. Like, why is it that African Americans continue to have disparities after decades? And I'm sure that this conversation was one that happened before me. But what is it like to be African American? Because we cannot be physically well if we are not mentally well. And we carry the stress. People will say, we need to cure your stress. You know, take this pill to fix your stress. But what about if I carry the stress of my mother and her mother and her mother and her mother? And now I have an epigenetic change in my DNA because I'm a stress carrier, because I'm a Black woman who has had to survive my experience in America. I've had to survive being Black, and I've had to use resilience. unapologetic resilience, because it's an expectation for me. What does that mean to my mental health? What does that mean when I have to wake up and what I choose to wear, what I choose to eat, how I choose to learn, how I define success, what I name my baby? It's all attached to another group of people. And then somebody wants me to somehow show up well. Well, I think we need to take these conversations a little bit back further to a more basic premise of just self-determination. We will never be a healthy community. We can't talk about hypertension until we talk about self-governance and self-determination. What is it like? I moved here from San Francisco. I'm a newcomer to Louisiana. And every day I have to drive through a parish called Jefferson Davis Parish. These are the microaggressions that Black people have to survive every day. And we're supposed to show up to a venue and act like that didn't happen. We're supposed to overlook conversations that happen in our community, conversations that happen outside of our community, and show up and do the work. Because our success in America is attached to how well we can function as that dominant culture. And that makes us sick. So we have to go back and start looking at how to build the components of our community that even our ancestors had. Because the smarter we get as a community, the sicker we get as a people. That's just a fact. And so I want to just quickly talk about, give you an example before I close, and that is working at SWLA Center for Health Service. Well, let me just say that we're going to do a community challenge, and we'd like to invite all of the healthcare providers throughout Louisiana to do a challenge in which we will commit to trying to make Black people well. We're going to have challenges around hypertension, around diabetes, but we're also going to have a mental health challenge. Please stay tuned to SWLA to hear about that challenge. We want to work with everyone. We're going to actually do the work. I learned that I have just a few seconds to wrap this up. But SWLA Center for Health Services was the clinic that had the first documented positive COVID case in Southwest Louisiana. And our woman, a Black woman, was sent to the hospital and she was not believed. Their question was, who told you you have COVID-19? So we continue to experience racism. We continue to not be believed. We continue to have to exist in this world as if things aren't happening to us, that they are happening to us. And we won't be well until we are able to make decisions for our own community. And I'm sorry I'm rushing because we have to go, but thank you for having me.
Thanks, Ms. Muhammad. And I'm going to punt it to Judy.
They literally sent me a message and said,
Thank you, Celina. Thank you, Celina. We appreciate hearing from those incredibly powerful panelists. I'd love to bring in Oliver Thomas now. We had some difficulties bringing him in at the beginning of the call. He's one of our guest speakers and we'd love to hear from him at this time. Oliver?
Yeah, can you hear me?
Yes, we can hear you.
Well, first of all, I want to thank President Morial and you as a CEO and President of the Louisiana chapter of the Urban League for this important discussion. You know, as a member of the local media, when I'm not working for my firm, I host a Good Morning show with Equity Media on WBOK. And we deal with these issues daily for the last several years. African American media, whether it's what we do on my show, the morning show, whether it's what we do, they do with the Tribune, Data News, or the Weekly, these issues aren't new to us. As I was preparing and watching the national discussion, it's been, you know, it's been kind of laid out like a competition, like Black people versus coronavirus. And as I thought about a list, it's not just coronavirus or COVID-19. It's Black people versus bad public policy, Black people versus violence, versus racism, versus economic disparities, versus gentrification and lack of access to affordable housing, versus health disparities that are caused by the communities they live in, and environmental racism and pollutants that are not of their doing, and of course, Black men and women, even in majority African American communities, versus unemployment and underemployment. This national conversation, to me, is pernicious at best, especially when I'm reminded of the late Dr. Morris F.X. Jeff, who Judy, your father, was very close with, who was one of our social scientists and intellectuals here, who talked about myth versus reality. I think like Dr. Levis and maybe a couple of others, I hate the fact that they're promoting this myth of us being physically inferior, whether it's our immune system or access to disease. Because as a little boy who grew up in the lower Ninth Ward, as I think about my existence in that poor community, we were extremely healthy in spite of racism. We had our own economics within those Black communities before integration. And our sobriety, our sanity, and our questions and our fitness wasn't in question until the war on drugs, until mass incarceration, and until critical economic resources of self-reliance left our community. So to me, it's been very disheartening to watch these national press conferences with medical leaders and public policy leaders and political leaders minus solutions that we know that are already there. And especially when I hear folk talk about promoting wellness and better physical health and better habits physically, well, what do we know? We know that even if we promoted those things and made some impacts in the area of health and wellness, unless we deal with economics, it's not sustainable. It's not sustainable at all. And it's extremely offensive when we talk about our community. And I'll just use an example. There's an African-American community that has a $10 million problem. Well, somebody gets a $100,000 grant to fix a $10 million problem. And Dr. Verrett said something earlier that I agree. We promoted on my show, Everyday Personal Responsibility. Yes, it is our responsibility to protect ourselves. But in this country where we brag about God on our side, where we put our hands on the oath to the Bible when we take office, when we say God is with us, when we compete, what you do for the least of these should probably matter here when you talk about economic and health and social and educational disparities. And then there's Matthew 25, 35 and 36. Hungry, you fed me. Thirsty, you gave me a drink. Sick, you visited me. And in prison, you visited me. Stranger, you invited me in. And I'm sure that would probably be amended in the 21st century today, that to say if you were neglected and if it was disparate with your community, we would probably fix those things. So for me, I would love to see some conversations, especially the conversations we have on Black radio and in Black media, about not just what the problem is, but those age-old solutions that we know would make a difference. And I think at some point, until we get the Urban League does this national state of Black America, and you put it out, Judy and President Morial, the work that you guys do is beautiful every year, but it should be adopted at the congressional level and instituted in terms of a work plan. It should be adopted in state houses throughout this country and instituted as part of steps towards a plan to deal with that report. It should be instituted and adopted at local levels, especially where we're being led by African-American men and women who are working hard to close the gap. So this conversation is an age-old conversation. The issues have not changed, but I will remind folk of a time in the 90s where many African-American cities, the late 80s and 90s, especially before the war on drugs and the infiltration of drugs and weapons in our community took over, where we had advances. President Morial, who was mayor then, increased the home ownership level to over 41% by impacting the African-American community, working with ACT in neighborhood housing organizations, the African-American middle class, their efforts that had started to grow. It didn't just happen. And I think what we see too often is that we have this idea about being fair and about making sure that everybody gets the same treatment. Well, if I have cancer and it's stage 4, and you have a sprained ankle, then the same treatment in terms of our wellness will not apply. And I think that's what we've tried to apply here. So until at some point we have a national agenda that is adopted statewide and locally, and until we have leaders that are willing to resource and invest in areas that don't need, we don't need your good wishes and your prayer for us to do better. We need critical resources so that we can begin to not just stem the tide and level the playing field, but stop the sins and the obscenities that are attacking our community right now. And all I can say that is we're going to continue to talk about these issues. We're going to continue on my show and with Equity Media, and I'm sure in other African American periodicals and media to deal with this. And I would just hope at some point that this conversation right now about Corona versus Black people continues in all those other areas, not just through this pandemic, but through the epidemic of neglect and abuse that we've had for too many decades. Thank you.
Thank you so much. And we have time for just one more question. And I want to punt this back to Ms. Muhammad. You know, we've gotten a question related to funerals. You know we are dealing with a lot of loss right now in our community. How can we as a community deal with death without traditional burials? What should people be doing?
Well, I believe that we have some tools like Facebook. There are some blessings to this technology. My grandmother recently passed, and I was able to, both my grandmother and grandfather, and I was able to FaceTime them every day. And so I think we have to find technological ways to keep in touch with our people while they're sick. And also, there's been some real innovative things done online. I think we may have to have some online funerals and have some conversation online. I don't think there's another option. So within this social distancing time, I think we have to be very creative and use technology.
Thank you so much. And I'll punt it back to Judy, but I did want to note, Judy, that Dr. Gee said that she wanted to let folks know that their app is also available in Spanish, lsu.khealth.ai. So punting it back to you.
Thank you so much, Celina. And once again, tremendous thanks to each and every one of our guest speakers, our health expert panelists. I have been receiving text messages throughout this Tele-Town Hall gathering saying how tremendously powerful each and every one of you are. I want to just run through some of what I have heard and what I have taken away from this. We must use data. We must be deliberate and intentional. We have to be strategic. We have to address racism and biases head on. We have to adopt health equity plans in health organizations across the state, follow the state of Louisiana's Department of Health's lead. We have to have near-term and long-term plans in order to address this issue. We cannot not have this conversation. This is a necessary talk. We have to protect our essential workers, and we must make sure that they are not treated as disposable workers. Federally qualified health centers provide access, but they also can provide information that will help to change the narrative about African Americans and people of color. We must address narrative change about who African Americans are, how they fit into the overall population, and make sure that they have seats at the table. We must give voice to the voiceless, and we must keep people healthy, educated, and working. And finally, I will say on behalf of the Urban League of Louisiana, you can count on us. We are an advocacy, policy, social justice organization that does programming across education and youth development, entrepreneurship, workforce development. We are here to support all of you on this call, all of your organizations, and this is not the last that you have heard about how we can do our part to work in partnership with many organizations that were on this call and who couldn't be on this call, but who are doing the work on the front lines to make sure that African Americans and other communities are being considered and that their whole health is being considered across the state of Louisiana. So thanks to all of you for participating. We did go a few minutes over, but we are so grateful and we were so honored to be able to give voice to all of the speakers and the experts that were on this call today. Celina, I will give you the last word. Let me just say to you, my sister, thank you for your partnership. Thank you for your leadership, and I have enjoyed so much working with you in order to bring this information to our communities across the state of Louisiana. Celina, the last word is yours.
Thank you, Judy. I'll just say To all, stay well and stay safe out there. And we'll talk to you next time and see you when the stay home mandate is lifted. Thank you all.